Good evening, everyone. Today is Sunday, October 9th, 2022. Today we'll be doing a caseless defense webinar. We'll be going till 10 o'clock tonight. With a show of hands, can you tell me if the audio is working? You can hear me. All right, perfect. Thank you so much. And before we start, does anybody have any questions? You can put them in the question box, or if you want to raise your hands right now and ask any question about anything before we start asking for people to be on the hot seat. I don't see anybody with their hands up. Does anybody want to participate and be in the hot seat? If you have not been on the hot seat for the last like 2 or 3 webinars, if you can keep those hands down for the time being so we can try and get people that want to be part of the hot seat and have not had the opportunity. So does anybody want to be part of the hot seat that's not been in the hot seat for the last 2 or 3 webinars? Just looking down the line here. Elizabeth, I'm going in your direction. Says you're self-muted.
Hi, can you hear me?
Yes. How you doing?
I'm good. How are you?
We're hanging in there. That's all we can do, right?
That's it.
So do you want to go through a specific case? Do you want a topic? What are you looking for?
I would say if we could do, let's just start with gyne today.
Okay, so you want to do something on your list?
Yes, please. Or
Okay.
or any topic that you would like to pick, I'm okay with as well.
It doesn't matter to me one way or another.
I don't have my, I'm sorry, I didn't have my case list up, so.
You don't have, oh, I'm pulling it up here.
Oh, okay, okay.
Yeah, I blacked everything out, so I'll put it up here in a second. You look. Just looking.
Okay.
You can see the list now, right?
Yes, I can.
Okay, case number 31.
Okay.
So how do you diagnose PID?
PID is diagnosed with a clinical diagnosis of the patient complaining of pelvic or lower abdominal pain, as well as either cervical motion tenderness, uterine tenderness, or adnexal tenderness.
Are you still there? Did I lose you?
Yes, no, I'm still here.
Okay. So you're saying you have to have lower abdominal pain and either cervical motion tenderness, adnexal tenderness, or uterine tenderness. Am I correct?
Yes.
So a very low bar is what you're telling me.
Yes, that is correct.
Why is that?
Because we do not want to potentially miss a diagnosis of PID because of the potential sequela of untreated PID that could lead to infertility or mainly infertility.
So what diagnostic criteria dictate inpatient management of PID?
As far as outpatient treatment versus inpatient treatment, the criteria for inpatient would be pregnancy, fever, inability to tolerate oral medication, concern for the diagnosis not being PID, and potentially maybe more time to rule out other diseases such as appendicitis, if that was a concern, an unstable patient, and concern for follow-up.
And what do you mean by unstable patient?
I should have stated better, maybe a patient that is vitally, if you're concerned about vital signs, or a worsening condition, potentially if there's concern that this could be a questionable diagnosis and there could be concern that the patient could decompensate. So you'd want to put inpatient management for closer following or monitoring.
And this patient was admitted for what reason?
This patient was actually admitted by another physician that was following her for a multi-drug resistant UTI, and she was complaining of pelvic pain and fever and was told to go to the hospital for imaging. And with the imaging result that came back concerning for TOA, they consulted me.
And with the suspicion of TOA, did they describe the size? What made him suspicious for a TOA? And I'm assuming that was on CT scan or ultrasound?
That was actually the CT scan. And so it was a 2.8 centimeter ovarian cyst that had peripheral enhancement. So I requested that a follow-up imaging with ultrasound be obtained, and that's what showed this complex an ovarian cyst in complex appearance with adjacent fluid that was concerning potentially for a TOA. So I recommended that, and then I went to see the patient, and she was having lower abdominal pain and uterine tenderness. So I went ahead and recommended that we begin oral antibiotics for suspected TOA. I'm sorry, IV. I'm sorry, IV antibiotics.
So what medications did you recommend? What antibiotics?
Ceftriaxone 1 gram IV every 24 hours with doxycycline, which could be given oral or IV, 100 milligrams BID, and metronidazole 500 milligrams BID.
And it was a 2.8 centimeter TOA?
Yes.
And in what time frame did the patient respond?
She responded within 24 hours. So she was transitioned from IV to oral.
And how long was the oral antibiotics? Which oral antibiotics, and how long of a regimen?
The oral was doxycycline 100 BID and metronidazole 500 BID for a total of 14 days.
Let's say the patient did not respond. What would you have done?
I would have then recommended a consideration for, a drainage, an interventional radiology drainage of the TOA.
That's if she hadn't improved, correct?
Correct. If she had not shown improvement, correct.
Let me give you another example. Let's say the TOA was 9 centimeters. Even though she may have responded to your initial antibiotics, would you have considered drainage? Why or why not?
Yes, I would consider drainage for any TOA greater than 6 centimeters and for a TOA that does not respond to antibiotics.
And why if it was greater than 6 centimeters?
I would suspect that's due to the size and concern for the antibiotics. I'm not sure how to word this for penetration of antibiotics in a TOA of that size.
Okay, let's stop there. What'd you think?
I thought it was okay, but I'm still very
No,
nervous.
I thought everything that you said was right on point. You didn't say
Okay.
anything that was wrong or out of turn. So very nicely done. Okay,
Thank you.
for everybody on the call, PID has changed. The primary or first line treatment according to the CDC is ceftriaxone 1 gram IV every 24 hours. That's for your inpatient treatment with doxy, and now flagyl is added. Previously, flagyl was added only if there was a TOA. Now it's in addition. You add regardless if there's a TOA or not. And the bioavailability of doxy and flagyl is the same PO versus IV, so it doesn't matter what way to give it. Doxy IV is very uncomfortable, it's painful, and it could blow the line. You could still give the cefoxitin as we did previously, but that's more second line. Yeah, I think everything you said was correct. And it's a very low bar for treatment. It's lower sexually active, lower abdominal pain, and uterine tenderness, adnexal tenderness, or CMT. So very low bar. Severe clinical illness, TOA, nausea and vomiting, pregnancy, no response to outpatient treatment, concern about follow-up, you should admit the patient. Previously, nulliparous should have been admitted, not anymore. For the most part, to my understanding, if you're HIV positive, you still could be managed outpatient unless you're not responding. So any other questions, Elizabeth? Very well done.
Thank you. I just do have one question. Was I
Yeah.
correct? Is it because it's the size of 6 centimeters that you're
Oh, yeah.
concerned penetration of
The concern, I think, I could be wrong, is those patients, they may respond initially and they'll come back several weeks later ruptured, and then she's sicker.
Okay. Okay.
But I believe the flagyl has very good penetration with the TOA, but that's a good size, good point. I've always, in my mind, it was like the patient is not, she may respond. I've seen this happen where the patient responds, she's sent home, and she comes back several weeks later ruptured and sicker. Because that's a big size mass full of pus, right?
Right. Right.
So maybe it's the penetration. I've noticed that it ruptures and they just get sicker. So you should definitely, now a 2.8 centimeter TOA might be tough for the radiologist to tap. So the smaller it is, hopefully they respond quicker, you hope. But if they're not, then you have to attempt to see if they can try and drain it. And I've seen sometimes radiologists drain with a vaginal approach via ultrasound, not necessarily CT.
Right.
I've seen that happen as well. I'm not a radiologist, but that's what I always suspected. But probably it might be penetration. But I know the flagyl has very good penetration of abscess.
Thank you so much.
Very well done. All righty, I'm just looking down the line here. Anybody else who has not been on the hot seat? Christine, I'm going in your direction. Are you there, Christine? Says you're self-muted.
Yes, I'm here.
Hi, how you doing? Are you a generalist or a subspecialist?
I'm a generalist.
Okay. Do you want a specific case to go over? You want a topic? What are you looking for?
No, anything.
Any specific section?
No, this maybe office or OB.
Okay.
Just because we suggested GYN.
Okay, I opened up your office here. Let's see. So no cases concerning you?
I think I just need to kind of dive in and look at all the cases a little more closely. I'm sure.
Okay.
Yeah.
You see the list, right?
Yep, I see it.
Okay. Case number 5. So you have a patient who presents secondary to unprotected intercourse. So she says to you, Doc, I'm concerned I could get pregnant. What management options would you discuss with the patient?
So first, I would want to know kind of more about the history of her more recent unprotected intercourse, how many days ago that occurred, in order, because that would guide my treatment options.
So let's say she says it was 2 days ago.
Okay, so 2 days ago, she has a few different treatment options for emergency contraception. It's this, I want to know, is this a desired pregnancy if she were to in fact be pregnant, or would she want emergency contraception? And
Let's say
then
she
also,
says, I'm interested in emergency contraception.
so then I would kind of go through the different options available. Since it is, within 2 days, she would be a candidate for either copper or 52 milligram levonorgestrel IUD, as well as if she wanted medical management, I would discuss, there's various methods. Generally, I prefer using the ulipristal, or she could use levonorgestrel in order to for emergency contraception.
Okay, so the ulipristal, what is ulipristal?
So it is a progesterone antagonist,
And
and
do you know the dosing?
I believe it's 30 milligrams,
And how many times do you take it?
just once.
And how many days is it effective once you have unprotected relations?
So it's my understanding it's effective for up to 5 days.
And what about the levonorgestrel? What's the dosing there?
So there's 2 different methods. You could give 150 milligrams one time, or she could take 75 milligrams 2 times, 12 hours apart. However, that would only be effective for up to 72 hours.
And what's the mechanism of action of Plan B?
So Plan B is a progesterone or progestin, so it thickens the cervical mucus and can help alter the environment within the cavity to prevent both the sperm from fertilization as well as implantation.
And what about the ulipristal? What's that mechanism of action?
So it's a progesterone antagonist, so I believe that would prevent the pregnancy from being able to continue. Or not the pregnancy, that would prevent fertilization, prevent implantation.
Between ulipristal and Plan B, which one's more effective?
Ulipristal is more effective, especially for patients with a higher BMI.
Why is that?
That's a good question. I think it's, my understanding is based on the mechanism of action, but I would have to look into that.
Now, is there any particular subset or class of patients that is not recommended for them to be on oral or receive oral emergency contraception? Let's take the IUDs off the table.
So a patient that had a contraindication for using either ulipristal or the progesterone based. I mean, I guess if they had a history of cancer, or if they were taking a medication that could interfere with the metabolism of the levonorgestrel, such as some of the anticonvulsant therapies, I believe.
So let's say the patient's interested in oral emergency contraception. Is there any testing or anything that you need to do prior to the patient receiving the medication?
In general, there's no routine testing that needs to be done that comes to mind.
I'm going to change things a little bit. So this patient 5, received the Nexplanon. She was interested in that for contraception, correct?
Yes, she was.
So what does the Nexplanon contain?
The Nexplanon contains etonorgestrel.
And how much?
That's something I would have to look up the dose. I don't know off the top of my head.
And
But
what's
it is
the
a
mechanism?
progestin only. Similar to
Mhm.
levonorgestrel, it's progestin only. So it has sort of a similar function in that it thickens the cervical mucus, decreases tubal motility in order to prevent sperm penetration and implantation.
What is its main mechanism of action?
Are you, sorry, maybe I'm not understanding the question. Is it one of the things that I just described or something that I'm missing?
You tell me.
So its main mechanism of action, from my understanding, is that it creates an environment that would prevent implantation and fertilization.
So what other contraceptive option contains the same progestin as Nexplanon?
I don't believe there are any other etonorgestrel containing contraceptions.
Okay, let's stop there. What do you think?
I think it was harder than I thought it was. Maybe to review the contraception.
Say again?
I maybe have to review kind of the more specific details because I kind of have like a general understanding.
So to my understanding, the Mirena IUD has not been approved yet. Studies have shown that it's effective as emergency contraception, but it's not been approved yet for that reason, to my understanding. When you look at the package insert for the Mirena, it says it has changed from 7 years of contraception to 8 years, but not, to my understanding, emergency contraception like the Paragard. So the Paragard's good for 120 hours or 5 days after unprotected relations. Ella as well, 5 days, 120 hours. Plan B is 72 hours or 3 days. Off-label use is 120 hours, 5 days. So it may not be as effective. Both the Plan B is 1.50 milligrams PO times 1 or 0.75 milligrams.
Oh,
you said 75 milligrams and 150 milligrams.
1.5.
The Olapristol is 30 milligrams times 1, and it's selective progesterone receptor modulator. Both oral medications delay or inhibit ovulation, they believe.
Okay.
The most effective is Paragard at 0.19% failure rate, which is pretty good. Olapristol is 1.4%. Plan B is 3%. There is no special testing, nothing you need to do in order to give anybody emergency oral. IUD is a little bit different, but oral emergency contraception. You could have a history of a VTE, cancer. There's no contraindication. I don't know if you want to give it to somebody who has cancer, but there is no contraindication. There's no special testing you have to do. You don't have to do a pregnancy test. It will not affect a current pregnancy if the patient is pregnant. So if a patient calls your service and says, I had sex 2 hours ago, I'm concerned I'm going to get pregnant, you could prescribe Plan B with a prescription without doing anything. There is some cases, like you said, possibly some epileptic medicine. I know like Sestiva, which treats HIV, it may affect the effectiveness of the medication, the Sestiva, not necessarily the emergency contraception, to my understanding. There is some literature, don't say literature's on the exam, that heavier set women, the oral emergency contraception may not be as beneficial, may not be as effective. So I can't tell you if Olapristol is better if you have a greater BMI. But there's some studies that say, but they don't go into more detail than that. Because if patient's concerned, you give it to them, right?
Yeah, I generally
Right.
recommend Ulipristal just for my patients with a BMI that's elevated, just because I recall reading that it was more effective.
Yeah, I can't tell you 100%. I know they're saying that if you're a heavier set, it may not be as effective, but to say yes, definitely the Ulipristal, I can't tell you that. So I'd have to review that myself. Nexplanon contains 68 milligrams of etonogestrel. Its main mechanism of action, according to the package insert, it prevents the LH surge, so it prevents
Ovulate.
or inhibits ovulation. So the thickening of the mucus, the environment of the uterus, kind of like Depo-Provera, are secondary causes, which come into play because the longer the Nexplanon is in place, especially towards that third year, the less effective it is in inhibiting ovulation. So those secondary causes come into play to prevent pregnancy. Believe it or not, the NuvaRing also contains etonogestrel. Yeah, I said that too when I noticed that.
Yeah, I didn't notice that.
Yeah, I didn't know that either.
Interesting.
Okay, so any other questions?
No, thank you. That was very useful.
Very good. Good job.
Thick.
All right, I'm going to see if anybody else wants to be part of the hot seat here. Oh, I see some questions. So let me see. Hold on. Oh, sorry. We got a lot of questions here. So sorry, what's the size of TOA to refer to IR? Realistically, you can refer anybody to IR. They may not have a good window if it's like a 2 centimeter TOA. I've always heard or read 5 to 6 centimeters. So what Elizabeth said, I have to agree with. And that's a pretty good size. So, you know, those patients may respond initially. Hopefully they would respond to the antibiotics and they'd be good. But I've seen cases where the patients do return with rupture of the TOA and they have pus all over the pelvis, and so they get sicker. So they have to undergo like a washout and go to surgery. So you'd like to avoid that if possible. Hopefully that answers your question, Ruby. Well, Simonetti, I could pick you and we can pick a topic. We don't have to have a case list. So if you want to be chosen, please raise your hand and we'll go to you. Ruby, I'm assuming the cutoff of the size of TOA, that was the question you were continuing on in the second question. Just let me know if you didn't. Charlotte says, would oral emergency contraception be less effective in a patient who had a gastric bypass? Ooh, good point. Well, they say the oral contraceptive pill is not as effective. They prefer, you know, the patch in those patients for birth control. I would have to look that up. You would think theoretically it would. I would have to look that up. So good point. You got me on that one. I mean, maybe she'd be a better candidate for the Paragard. Again, the Mirena still has not been, to my understanding, approved for emergency contraception, but yes. What weight is heavier set? Would we say 200 pounds or a BMI of 35? I think I once read a BMI greater of 32, which isn't that much if you think about it when we deal with the patients we deal with, because mostly everybody has a BMI of 30, over 30 anyway, Jennifer. But I believe reading that once, I would have to double check that to see. Maybe the package insert of Ulipristal will specifically say it's more, you know, or the package insert for Plan B saying if you're a certain way, it may not be as effective. I would have to check that. Okay. the regimen, of PID in pregnancy. Ooh, this is from Carolyn. I mean, wow, you got me on that one. You can't give the doxy. Good point. I mean, I would have to check on that. I think there's a gent and a Clinda. If you look at the CDC, because CDC has a lot of different options. So I'm sure there's a gent and a Clinda, or, and it says if somebody has an allergy. So I would refer to the CDC website because it's very specific and clear in different regimens. Okay, but that's a good point because you really can't give the doxy, okay, when you're pregnant. Okay. Plan B failure rates, it is 3% for Plan B, 1.4 for ulipristal, and 0.19% for the Paragard. This is from Up to Date. So hopefully that answers your question, Lindsay. So if I didn't answer your question, just please let me know. No, to my understanding, no, Andrea, Nexplanon cannot be used for emergency contraception. Okay, no, that's not one of your choices. Okay. Abby, I'm going in your direction. It says you're self-muted. Are you there, Abby? It says you're self-muted, Abby. You have your hand up. Are you there, Abby? Now it says she's not attentive. Okay, so I'm gonna have to go on to somebody else. Sorry, Abby. Still says you're self-muted. Alexandra, I'm going in your direction. Says you're self-muted. There you go.
Can you hear me?
There, Alexandra? Yeah, can you hear me?
Yes.
Awesome. Are you a subspecialist or a generalist?
A generalist.
All right. Any specific case you're concerned about?
No, we can just do OB since we did GYN in office. That's fine.
Okay. Let's see what we got. Look over your list here. Give me a second. You have a big list, eh?
I know.
Jeez Louise. Jeez. Híjole.
I know, it's bad.
And you got to know all these cases. I feel for you.
Yeah, that was painful.
Yeah, I'm sure making the list was painful.
Yep.
Sorry.
That's okay.
Alrighty, well, we're going to talk about case number 1. So how do you determine chronicity and amnioticity in your twin gestations?
Yeah, so with twin gestations, it's best to determine chorionicity in the first trimester with a first trimester ultrasound. That's going to be what is more accurate.
And what are you looking for?
With these ones, typically one of the things you can look for is the twin peak sign or the lambda sign. That's going to determine whether or not this is going to be a dichorionic, diamniotic twin gestation. You can also look for, it's escaping me. I think there's one more thing, but I typically just look for either the lambda or the twin peak sign.
Is there anything else that could be indicative of a chronicity or an amnioticity?
The gestational sac. You can look for the presence of gestational sacs. I think there's something else, but it's escaping me.
How would you calculate trig discrepancy or discordancy in a twin gestation?
So discordancy with twins is going to be based off of the larger twin. And typically if the larger twin is 20% bigger, then that would be considered a discordant growth.
So between these two twins, how would you calculate their discrepancy or discordancy?
Based off of their growth, like how to do their growth ultrasound?
No, how to calculate their discrepancy mathematically.
Oh,
Yeah,
I do
usually
not know.
the MFM tells you that, but you should know how to do it.
Yeah, I don't know how to do that.
Okay.
I'd have to
Now,
look
can you
that one.
discuss? No worries, we'll talk about it here in a second. So discuss the timing of ovum cleavage in twins for me.
Yes, of the, you said like the separate, like the cleavage of the egg.
Yes.
So this is going to determine what type of chorionicity you have. So the earlier this happens, if it happens between day 0 to 3, that's going to result in a die at twin gestation. If it happens to day 3 to 5, that's going to be your mono-die twin gestation. 5 to 8 is going to be mono-mono, and then past 8 is typically when you see conjoined twins.
So past 8 days, you said, is conjoined twins?
No, it's going to be, I'm sorry, I think it's 13 days.
Okay. Now, in this particular case, she had a repeat cesarean because she declined a TOLAC, correct?
Correct.
So why was the patient delivered at 36 weeks?
So she was an interesting case, kind of one of those patients that was in and out of the hospital because she got severe pain early on, which was what led to her ERCP. And then her having that complication was followed pretty closely with serial growth ultrasounds, and twin A was found to have fetal growth restriction. And together with my MFM, they made the recommendation to deliver her at 36 weeks. One, because of the fetal growth restriction, but two, her pain was getting pretty significant. Even after she got kind of some relief of her pain at 29 weeks after her ERCP, but then it started to come back. And so they recommended giving her some steroids and then delivering at 36 weeks.
So what's the mechanism of action of betamethasone?
So with betamethasone, we give that to promote mainly fetal lung development. And this is done, I believe, my gut wants to say it does help increase surfactant, but I don't know if that's true. But yeah, I'd have to look at that one.
And what was the positions of these twins before delivery?
They were cephalic and breech.
So let's say the patient really wanted to have a trial labor and deliver vaginally. In what situation would you not deliver a vertex, non-vertex twin gestation vaginally?
Yeah, so there
Or
are.
you be more cautious, let's put it that way.
Sure. In these situations, you want to know and document the estimated fetal growth for both of these babies. Typically, you would like the presenting twin or the twin that is vertex to be larger in this case. If it was slightly smaller, then you might have more complications with a vaginal delivery.
What complications?
Where the second twin or the non-vertex twin could be either a head entrapment or a shoulder dystocia.
What do you mean by shoulder dystocia?
If you were able to flip the non-vertex twin to vertex, but because it was a larger twin, you could have a harder time delivering that baby, or it could lead to a shoulder dystocia.
Okay, I never had heard that. Okay. Anything more specific in regards to a situation that you would not deliver vaginally, especially for that second twin?
If there were any sort of like congenital anomalies associated, that would be a contraindication to a vaginal delivery. And that's
Anything
all I
else?
can think of right now.
Okay, let's stop there. What'd you think?
I thought it was okay. Not
Let's
Terrible.
think about it. Yeah, whatever. Yeah, I think you did well. Okay, couple of things. Chronicity, amnionicity, usually via ultrasound, the junction of the membrane with the placenta, mono, flat T sign, di, twin peak, lambda sign. The thickness of the intervening membrane, di, is greater than 2 millimeters, mono is less than 2 millimeters. Layers of membranes, di is 4 layers, mono is 2 layers, appearing thin and hair-like. How do you calculate discrepancy/discordancy? You subtract the larger twin from the smaller twin divided by the larger twin, multiply it by 100.
Okay, so larger
Okay.
minus smaller divided by larger times 100.
Yep,
Okay,
because I'll give you
got
the
it.
percent. The timing of the ovum cleavage on day 2 to 3, that's di-di twins, usually 30% of the time. Day 4 to 8, mono-di, 68% of the time. Day 9 to 12, mono-mono, 2% of the time. Greater than day 13 is the conjoined twins, as you said.
Okay.
In regards to a vertex, non-vertex, if twin B is less than 1,500 grams, less than 28 weeks, and there's discrepancy in weight of more than 20%, you should not deliver that baby vaginally. You should do an external cephalic version. I've never heard of there being a shoulder dystocia. It'd be more of a head entrapment. Because when you're less than 1,500, less than 28 weeks, the head is much bigger than the body. So that's the concern with the breech presentation. Am I making sense?
Yeah, no, I was just thinking of it like flipped to cephalic and then that B was bigger than A.
It shouldn't. Why would it make a difference between A and B for a
Yeah,
shoulder? It would happen if it was a singleton anyway, right?
I guess my
I
mindset
don't
was
think that would
thinking,
increase that risk. I could be wrong, but I don't think it would increase that risk.
yeah, I guess I was just thinking that A is significantly smaller than B, so then it would have an easier time coming. But this is, yeah, it's silly. It's fine.
It'd be more, because the concern is you want twin A to stretch that cervix really well to prevent that head entrapment for twin B. That's why if twin A is much smaller, you should be very cautious of delivering twin B as a breech.
Right, exactly. Right. Okay. Yep, that
So
makes sense.
not necessarily, I don't think so more so for the shoulder, it'd be more for that head entrapment.
Mhm.
Betametha accelerates the development of type 1 and type 2 pneumocystes, leading to structural and biochemical changes that improve both lung mechanics and gas exchange. Induction of type 2 pneumocystes to increase surfactant production. So you were
Oh,
correct.
great. Cool.
Okay. All right. Any other questions? I think we covered all that we asked you.
Yeah, no, that's good. Thank you.
Anything else? Okay, very good. Thank you. I'm here looking, see. Can I repeat the numbers you stated in regards to dichorionic versus monochorionic? Sure. You have the thickness of the intervening membrane. Di is greater than 2 millimeters. Mono is less than 2 millimeters. The layers of the membranes is di, 4 layers. Mono is 2 layers, appearing thin and hair-like. Does that help you there, Jennifer? So what about having an OB trained in vaginal breech deliveries as a necessity for vertex breech deliveries? You know, perfect world, that'd be great. But of course, on this exam, they're going to say they're not available. So they're going to push you to do that delivery, Elizabeth. Okay. Lindsay, did I answer your question? Okay, awesome. Oh, I like your comment there, Alyssa. Thank you so much. Anybody else want to be part of the hot seat here? Let's take a look. All right, Simonetti, we're going in your direction. Are you there?
Yeah, I'm here.
All right, awesome. So we'll do a topic. Where do you want to do a topic from?
How about something from OB?
Are you a generalist or a subspecialist?
A generalist.
Okay. All right, can you tell me the different perineal lacerations that can occur?
Yeah, there can be first, second, third, and fourth degree lacerations.
Can you be more specific for me?
Sure. First degree is just involving the vaginal mucosa or the epithelium of the perineum, so not very deep. The second degree is deeper. That involves laceration of the bulbocavernosus muscles and the superficial transverse perineal muscles. Then when we go into the third degree laceration, it's divided into three categories, 3A, B, and C. And this is they differ by the degree of involvement of the external and internal anal sphincter. So 3A is less than the external anal sphincter is involved, 3B is greater than 50%. Sorry, 3A is less than 50% of the EAS, 3B is greater than 50% of the external anal sphincter, and 3C is involving the internal anal sphincter. And last but not least, and the most undesired laceration would be the fourth degree laceration, which involves the rectal mucosa.
So can you describe for me how you would repair a fourth degree laceration?
Yeah, first of all, I'd want to identify it. So I would do a rectal exam with a sterile glove up top and confirm that the rectal mucosa is indeed involved. I would then take that glove off and inform my nurse, charge nurse, to this patient has a fourth degree laceration. We should have an operating room ready. I would inform the patient about this laceration, that it requires a more complicated repair, and that I would want to take her to the OR for appropriate visualization and optimal repair. I would also call in a colleague because this is rare and difficult, and I would want to make sure there's a second pair of hands to aid in the repair. I would then focus on repairing the rectal mucosa. I would use I would repair this in a running fashion with a 4-0 monocle, but I would have to double check that. Then I would repair the external anal sphincter. I'll try to identify the internal anal sphincter, but it's often not visualized. If I can't visualize it, I would repair the external anal sphincter end to end. I'd use a 3-0 vicryl, and I would repair them with 4 to 5 interrupted sutures in the anterior, posterior, inferior, superior direction. So all surfaces of the cut muscle are touching. And then I would repair the remainder of the incision, laceration as a typical second degree. I'd also give the patient antibiotics to reduce risk of infection.
What antibiotic?
Cefoxitin, 2 grams, pending that they don't have any allergies.
And how often?
A one-time dose.
Just a one-time dose? You want to do a 24-hour dosing?
No.
What else would you do after the repair?
I would inform the patient of what the implications this has for her. I would definitely have her on a stool softener to make sure there's no risk of leakage of stool and causing infection. I would give her some restrictions on mobility in the sense I wouldn't have her squat or do anything that would put strain on the laceration, so that have it heal appropriately or to optimize its healing. I would have her come back in a week at least to make sure it's healing appropriately. I'd tell her about the increased risk of fecal incontinence from weakening of that muscle. And then I would also talk to her about future delivery plans, not immediately then, but if this is a particularly traumatic experience for her, obviously I'm sure it is, and she wants to avoid this in the future, she should consider a cesarean section.
Anything else that you would recommend to help with her healing?
I mentioned stool softeners, avoiding squatting, antibiotics, other than the routine, keeping an eye out for signs of infection, bleeding, tenderness. Nothing else comes to mind. Increasing protein intake. Sometimes I say, I don't know if there's evidence behind that, but.
Anything else? Something, I think you're reading too much into it. Something pretty simple that the patient can do herself in order to improve her healing and her repair.
You're not implying a Kegel exercise? I don't think that's it.
Okay, Kegel exercises, but something more. You can physically go to a place and they'll help you.
Oh, pelvic physical therapy.
Yeah, so it's recommended that these type of patients definitely should be set up for pelvic physical therapy to hopefully improve that healing. What is the risk of repeat oasis, for lack of a better word, in the subsequent vaginal delivery?
It's higher than the average population, but it would be lower than the risk that she had with her first delivery. That makes sense. So she's less likely to have the 4th degree next time as she did with this pregnancy, but she's definitely at much higher risk than average.
Can you give me a number? I'll let you guess.
I'm gonna guess 10%.
Okay, so let's say the patient's like, doc, I really want to try and have a natural delivery or vaginal delivery next time.
Mhm.
You're taking care of her
Mhm.
for that pregnancy, and you're going to be doing that delivery.
Yeah.
What can you do in order to decrease the risk of a repeat 4th degree occurring?
Yeah, I would apply warm compresses on the perineum to allow for the tissue to kind of soften, and I would obviously, as always, but try to control the delivery so that the skin is stretched in a timely fashion and not abruptly. Those are the two main interventions I do at the time of delivery, or at least in the second stage. Other things I just keep in the back of my mind are, if this baby seems bigger, or on ultrasound or on Leopold's, I would, counsel her through her pregnancy to say that, this could potentially, if this baby's bigger than the first, this might increase her chance, theoretically.
Anything else you can do? Something actively that you can do that hopefully decrease that risk?
I'm guessing here a little bit, but I feel like this could be the right answer, a totally wrong answer. But an episiotomy,
Why would that be the wrong answer?
Because I feel like when I think of episiotomy, I always think of its worsening lacerations. But I think if I do a mediolateral,
how can it worsen? How can it worsen the laceration?
That's true. In her case, it's pretty bad. I mean, how can it? Well, I mean, it creates
If you did a midline, take the midline off the table.
Yeah.
So you would do a right medial lateral, correct?
Yes, and that would decrease her chance of 4th degree because the direction of the tear would be away, hopefully, from the rectum.
Right.
More.
Her tissue is already affected.
Correct. Yeah.
So she can have a chance of it occurring again because just of the scarring that she had from before.
Yes.
So the energy has to go somewhere. Wouldn't it be better to do an episiotomy, not midline, RML, in order to, or LML, depending on if you're left-handed, in order to have that energy go somewhere else?
Yeah, that certainly makes sense. So yes, I would consider an episiotomy, right or left medial lateral, depending on my preference at that time.
All right, let's stop there. For some reason, everybody thinks that doing an episiotomy is a bad thing. For some reason. I mean, if she wants to try and have it natural, I mean, I wouldn't chance that she's gonna not tear.
Yeah, it makes sense.
She had a 4th degree. She had a 4th degree. It's not a good thing.
Right, exactly. So in this case, it would actually help. So I think they just try to drill that into us so that we don't do that.
I know, but they just make it sound like, the worst thing in the world is to do an episiotomy. The worst thing in the world is to get another 4th degree.
Exactly.
Or a 4th degree or a 3rd degree for that matter. You might as well get a C-section, in my opinion, but what do I know?
Yeah.
Any specific questions before we go over this one?
No.
All righty. So according to the practice bulletin, the perineal skin is a 1st degree. I was taught the vaginal mucosa, a tear in the vaginal mucosa. So now it's the perineal skin. It makes no sense to me, but that's what the practice bulletin says. Then a secondary is the perineal muscles, like you said, the bulbocavernosus, transverse perineae, and you were correct with your 3A, 3B, and your C.
Mm-hmm.
Okay. Expert opinion suggests that a woman may be offered a C-section if any of the following is noted after a 4th degree: anal incontinence, complication of a wound infection, or need for repeat laceration repair, or a patient expresses psychological trauma. Risk of repeat oasis is in a subsequent vaginal delivery is 3 to 5%. This is according to the practice bulletin.
Okay.
25% of women experience wound breakdown and 20% wound infection. You can get anal incontinence, rectal vaginal fistula. Women who sustain severe perineal lacerations in the first birth are significantly more likely to have an associated surgical procedure within the first year after birth. After you do your repair, a single dose of antibiotic at the time of repair is reasonable, but further research is needed to determine routine administration to prevent complications. Avoid constipation, adequate pain control, focus on local treatments, anesthetic sprays, ice, sitz baths, consider pelvic physical therapy. Okay, we repair the anal mucosa using a continuous non-locking 3/0 4/0 vicryl on a tapered needle. You can also use monocryl. Interrupted sutures can be performed. However, it can result in a larger amount of foreign body because of the multiple knots. The internal anal sphincter often retracts laterally and superiorly and appears as a thickened, pale, pink, shiny tissue just above the anal mucosa that some clinicians refer to the perirectal fascia. I personally have never seen that. Continuous 3/0 vicryl or 3/0 PDS on a tapered needle. To the external anal sphincter, you grasp the two severed ends of the dark red external sphincter muscle with Alice clamps, and you know how it could retract. You have to find. You may need to push the Alice clamps into the surrounding connective tissue since one or both ends typically can retract. So you perform either an end-to-end or an overlapping plication like you said, okay? Using interrupted figure of eights of 2/0 or 3/0 PDS or 2/0 vicryl on a cut 1 or 2 needle. After the sphincter is repaired, you need to rebuild the distal rectal vaginal septum and perineal body. You want to thicken that tissue. This helps maintain the proper spatial distance between the anus and the vagina and may prevent suture erosion from the deeper layers. Another goal of this layer is to help take tension off the underlying sphincter repair, and then use a 2/0 vicryl on a cutting needle to repair the second degree in a routine fashion. Okay, so questions on that?
No, thank you.
Very good. Good job.
Thank you.
I want to see if anybody has any questions. Okay, hold on. I see some questions here. So I see, what is the role of NIPS in determining twin status? I don't know what you mean by that, Angie. I have no idea what you mean by that. Can you repeat the twin chronicity with the days when you get a chance? I'm assuming you're discussing like the ovum cleavage. Is that what you're saying there, Vinny? I think that's what you're indicating. So day 2 to 3 is di twins, 30% of the time. Day 4 to 8 is monodi, 68% of the time. Day 9 to 12 is mono, 2%. Greater than 13 days is a conjoined twins. Okay. Not sure if I'm clicking on the right thing, but my hand is up. Okay. For breech second twin, I was always taught 32 weeks, not 28 weeks. Well, Priyanka, this is what I saw on Up to Date. So I don't know what to tell you. I'm not an MFM. Maybe we have an MFM on the call. If you're an MFM, just type what is recommended. This is what Up to Date indicated. I still don't understand what you mean, Anzi, about non-invasive perinatal screening. What about the cell-free DNA? Not quite sure what you're indicating. Are you saying that'll tell you? Can you use cell-free DNA to determine chronicity? I don't think so. I mean, I guess if the DNA is the same for both, I guess. I have no idea. I never even thought about that. I'm not an MFM, so I could not, because usually in the past, the way you do your chronicity, amnionicity is via the ultrasound, the lambda sign, the thickening of the membrane and stuff like that. So I don't have an answer for you on that one. So everybody's now chiming in. So hold on. It's this booming up here. Hold on. Let's see. So with regards to the second twin, if B is non-vertex and it's less than 1500, less than 28 weeks, or greater 20% discrepancy, then we do a C-section or try to do an ECV after delivery of twin A. That's what Up to Date recommends. Okay. Again, I don't know about the 32 weeks. So Jay says Natera can tell with their cell-free DNA test. I guess Jay says that you could tell the twins their chronicity by that, I guess, because it's identical. There you have your monodies. So it says Pearls of, this is Priyanka. Pearls of Excellence says 32, and I am an MFM fellow. That is why we always practice also. And no, NIPS cannot tell you chronicity. I'd have to review that, Priyanka. Again, I'm not an MFM. I defer to you. This is what the up-to-date said. I can review that. This was as of last year. Maybe it got updated. So I don't have an answer for you there. I got to defer to the MFM, so I'm not an expert. So Elizabeth is saying, I think the NIP can be used to determine different sex to confirm die-die. So Melissa is saying some NIP tests can tell you zygosity now. Okay. Can you repeat the estimated gestational age for twin vaginal delivery again? So to my understanding, die-die twins at 38 weeks, 34 to 37 weeks is mono-die, mono-mono 32 to 34, but preferably more 32 weeks. Melissa's saying, but if you get a monozygote result, you don't necessarily know if they're mono-die or die-die. Good point. Good point on that, Melissa. Okay. So Priyanka, I have to defer to you. This is what up to date says. So I know when I trained, it was less than 32 weeks. But then when I read that, I'm like, okay. But when I trained, it was 32 weeks as well. So hopefully we're up to all everybody's questions. Anybody else want to be part of the hot seat here? And if I have not answered your questions, please chime in the box and we'll get to there. Andrea, we're going in your direction. Are you there, Andrea?
Yeah, I'm here.
Awesome. You want a specific case? You don't care? What you looking for? What's your poison?
I think we've done enough OB for now. Maybe we can do something else.
Okay, whatever you want. You guys run the show.
Office or GYN is fine. I don't really care.
Okay, let's see your GYN. Let's see what we got. You're a subspecialist, generalist?
No, a generalist.
Okay, generalist. Okay, just making sure. I'm just looking.
It's okay. I can't really see your screen, so I'll open it from my end.
Oh, I'll turn it on here in a second.
Okay, thanks.
Don't you worry.
Oh no, won't worry. I'm sure you'll find something.
I had something and I lost it. Booger. Let me look for it again. Case number 11.
Okay, 57.
So how do you prevent fluid overload in your operative hysteroscopies?
We're talking about, well, I think it'd be the same thing if you were doing in office versus the OR. So one of the things that I would do to prevent fluid overload would be to make sure that the machine is working. Make sure that I'm able to see how much there's the fluid deficit, how much is coming in, how much is coming out. Use as much, the minimal amount that I need to adequately see the uterine cavity. And anything else that I would do to, that's pretty much it.
Anything else?
Not to my knowledge at this point. I'd have to look that up.
At what point would you become concerned about fluid overload during your operative hysteroscopy?
So usually we use normal saline during our operative hysteroscopies. And so normal saline has I would be concerned with a volume of 2,500 cc's. But I usually don't go past about 2,000, just to be on the safe side.
And what's the other type of fluid you could use?
You can use sorbitol, glycine, mannitol are the other ones that you can use as well.
What type of fluid is that called?
I want to say it's isotonic versus hypotonic. I think isotonics are your normal saline, and the hypotonics are the mannitol, sorbitol, and glycine.
So what's the maximum there?
So with those, it's about 1,500 cc's. If it's a patient who has cardiovascular issues, it would be 750 cc's, I believe.
So case number 9, you said you noted Asherman syndrome.
Yes.
What is Asherman syndrome?
Asherman syndrome is a syndrome in which we see intrauterine adhesions that could be caused from a previous infection in the uterine cavity. It could have been a very, I guess, aggressive suction DNC, or an aggressive handling of the endometrium as well.
So I know this patient's 54. Let's change it. Let's say she's 24.
Okay.
How would you diagnose Asherman syndrome in your office? Or suspected Asherman syndrome, I should say.
So usually I actually have a case, I think, very similar, but this is after the fact. So usually a patient like this would, present to me saying that, she hasn't been able to get pregnant. She's been trying for about a year now. She hasn't been able to she hasn't been able to get pregnant. And, we do a full workup, and mostly everything is negative. And then usually I elicit some form of history suggestive of either, TOPs or a uterine infection in the past. And usually what we end up doing is, as part of the workup, either a hysteroscopy in the office or SIS. And that's usually where we can diagnose it.
Is there any way you can do a trial of some medication?
Yes, you can. You can use estrogen. You can use you can use some form of PO estrogen in order to alleviate or try to take out the uterine synechia, so that you don't keep on having those adhesions. And then you can have her for a couple of weeks, and then reevaluate doing another SIS to see how well the PO medication worked.
So you're saying that you could give estrogen and that'll resolve the synechia?
It can significantly improve the synechia, to which point maybe you can take her to the OR and maybe surgically remove the synechia.
So how does the estrogen help with the synechia?
I'd have to think about it. I'm not quite sure. I'd have to get that information for you.
So do you know what a progesterone Provera challenge is?
So yeah, usually Provera challenges we do when we have a patient who has abnormal bleeding patterns, to see if with the progesterone, with the Provera, they're able to get a menses. Usually we give it, we give the medication, and then after taking the medication, we should see a bleed after the administration.
So let's say you don't see a bleed, what would you do?
If I don't see a bleed, then I would think that maybe there's some form of obstruction going on. Maybe you can do a hysteroscopy, see if there's, do a really, I guess, an adequate pelvic exam, make sure there's nothing obstructing the canal or anything obstructing the cervix that you would think that she's not being able to have a menses. You can do a hysteroscopy, see if there's anything that's obstructing there, and maybe even an SIS as well.
Anything else you could do medically to confirm that there could be a possible obstruction or an issue with outflow?
Medically? Not that I can think of at this time.
Okay, let's stop there. What'd you think?
That was a little difficult.
Okay, so how do you prevent fluid overload during operative hysteroscopy? You use isomolar fluid, monitor fluid deficit, maintain the lowest intrauterine fluid pressure. You limit your surgery to less than an hour.
Okay.
And also you can apply or inject vasopressin in a like paracervical type of block, and that should also decrease your absorption. Some
Okay.
studies have said, you don't say studies. This is according to UpToDate. At what point would you become concerned about fluid overload? In isomolar fluid is 2,500 cc's, and hyperosmolar, the glycine, sorbitol, mannitol, is 1,000 cc's. Okay,
Oh, 1,000.
so
Okay.
Asherman's usually it's scarring, usually after a DNC. A lot of times it's more associated after postpartum DNC, usually. It's what UpToDate says. So
That makes
you
sense.
give somebody a progesterone challenge, a Provera challenge, they don't have any bleeding. Okay? So
Right, 'cause
then
there's no blockage.
it'll
Okay.
so then you're supposed to give them progesterone with estrogen. If they still don't have any bleeding, that tells you they have an outflow tract problem or they have Asherman's.
Okay.
Make sense? So if you
Yes.
give somebody progesterone alone and they have any type of bleeding, even a spot, that tells you they have estrogen in their body and it's working, right? They're,
Okay.
you have somebody who hasn't had a period in like 6 months or something and whatever. You're like, oh, what's going on here? You give her a progesterone challenge. If she has any type of bleeding, it tells you there is some type of estrogen somewhere in her body. So
Okay.
let's say she doesn't bleed, then you give her the progesterone estrogen trial. And if she should bleed with estrogen, right? If you give an 80-year-old progesterone and estrogen, will she have bleeding? Yes, she would have, right?
Yep.
I could give an 80-year-old birth control pills, and with the progesterone and stuff and the estrogen, she should have bleeding. So if you don't have bleeding, you have to worry there's an outflow tract or she has Asherman's. And the only
Okay.
way you can, to my understanding, resolve Asherman's is to take them to the operating room and break down the scar tissue. And some people put a Foley in, then put them on estrogen in order to prevent that tissue to scar down again with putting the Foley and the estrogen. Sometimes they don't put a Foley in, they'll just give estrogen because you don't want that scar tissue to reform again.
Would an IUD also be appropriate in these cases?
I'd be leery to put an IUD in because you just kind of cut her raw.
Okay.
Because of her scar tissue, and would that reform things and cause that IUD to get stuck? So I would leave that at a later time.
Okay.
Doesn't mean she won't in the future, but not at that particular time. I'd rather put a Foley in or give her estrogen. I'm not an REI, but that's what the book says.
Okay.
And I know somebody who specifically got that question asked 2 years ago on the exam.
Okay.
So it is fair game. Not that we do that many progesterone challenges anymore.
Yeah, no, I did
Yeah.
not do a progesterone challenge on this
Yeah,
patient.
exactly. I saw it and it just came to mind. All right.
No,
Other
that's
questions?
great. That's great. Thanks.
All right. Very good. Good job. Okay, I'm going to see if anybody has any questions. So what dose of vasopressin? I think you give 10 units or 20 units in 100 cc's mix, if I'm not mistaken, depend on who you read. So hopefully that reviews that for you, Christine. So Shalipi's saying typically vasopressin during hysteroscopy should be given in the cervical stroma, not paracervically. Also must be aspirated to prevent vasopressin intravascularly. Well, that's of course a given, which I have personally done, unfortunately. I always thought it was a paracervical. I'd have to reread. It's the hysteroscopic section on the up to date that said that. I didn't specifically say cervical stroma. I have to defer to you then, Shilpi. Okay. So Hannah's saying committee opinion says a randomized double-blind study of 52 women used 20 cc's of dilute solution, 4 units of 0.05 units per cc of vasopressin and 80 cc's of normal saline. So I don't know how they picked that. Again, I guess I defer to what the committee opinion says. My apologies on that one. Because I've read 10 to 20 and 100 cc's of normal saline. The key here, you don't directly infuse it straight up, because that would not be a good thing. Okay. Alrighty, anybody else want to be part of the hot seat here? All right, Charlotte, I'm going your direction. You're there, Charlotte?
Yep.
How you doing?
Good. How are you?
You're a generalist, correct?
Yes.
All righty. Are you looking for a specific
No, any topic would be fine.
case? Doesn't matter. What section are you interested in?
Any section.
I'm just looking, okay? Case number 9. How do you diagnose premenstrual dysphoric disorder?
So for premenstrual dysphoric disorder, they need to have had symptoms the majority of months over a year. There are lots of different symptoms that can be consistent with premenstrual dysphoric disorder. I think they have to have at least 5 different symptoms, and the timing of the symptoms has to start in the week leading up to menses, and then end within a few days of the start of menses, and at least one of the symptoms has to be affective symptom, so one that's mood related.
So what's the difference between PMDD and PMS?
PMDD is a more severe form of PMS, and yeah, patients have to have more symptoms. With PMS, patients typically do have a mood symptom, but it could be more physical symptoms, but PMDD always involves severe mood symptoms.
Now, you said you had to have a certain criteria or certain symptoms. Can you go into more specifics?
So some of the most common symptoms that patients would have would be irritability, labile, mood. They can have headaches, bloating, breast tenderness. Those are some of the possible symptoms.
And are there any particular symptoms that have to be present to meet criteria?
Mm-hmm. For PMDD, they have to have a mood symptom, like irritable mood or depressed mood.
Anything else?
The symptoms have to significantly impact their daily functioning.
So this patient, you started her on like what, Yaz?
Yes, I typically will recommend Yaz or Yasmin for these patients because the drospirenone containing OCPs are the ones that are FDA approved for PMDD treatment.
So let's say she doesn't really feel that it improved her symptoms. I'm changing the story a little bit. What other options are available?
Another option would be an SSRI or an SNRI. This patient was already taking an SNRI, but if she weren't on one of those medications, then we could start her on one either taken just during the luteal phase of the cycle or daily.
Seeing that she was on the SSRI, any other options?
I don't think there are any other mood medications that are specifically approved.
Any treatment, not necessarily medication, any treatment.
Oh. Yeah, so psychotherapy could be an option.
Anything else?
I would recommend exercising around the time of the onset of symptoms. That could help with symptoms.
Anything else?
I think any medication, any hormonal medication that suppresses ovulation should have some improvement in PMS or PMDD.
Okay, let's stop there. What'd you think?
Thought it was okay.
Yeah, I thought so too. Very good. So this is all from up to date. So at least 5 of the following with at least one core symptom present a week before the period and remit a few days after the onset of the period. So the core, like you said, mood swings, depressed mood, sudden sadness, increased sensitivity to rejection, anxiety, irritability, sense of hopelessness, self-critical thoughts, tension, feeling on edge. And or 5 of the following: difficulty concentrating, change in appetite or overeating, diminished interest in usual activities, decreased energy, feeling out of control, breast tenderness, bloating, headache, joint muscle pain, weight gain, changes in sleep, and symptoms that interfere with their life. Like you said, with PMDD, it's severe premenstrual disorder with impairment. PMS is mild to moderate disorder. Functional impairment is not required. So you want stress reduction, change in diet, exercise, that's beneficial. You could do SSRIs, anxiolytics. You could do bispirone, 5 milligrams BID during the luteal phase. I don't think that she would be a candidate because she is on a serotonin and norepinephrine reuptake. So you can get that serotonin syndrome, I think. I think it's I would have to double check that. I know the bispirone is not specifically the SSRI, but it does affect stuff in the brain, so it could be an issue. So I agree with you. I'd be very cautious with that. And of course, your OCPs. So usually they'll do well on the OCPs, but just wanted to see what you would say.
Thanks.
Saying it didn't work or something. All righty. Other questions?
Not for me.
Good job. All right, see if we can get somebody else in. Priyanka, I'm going in your direction. Says you're self-muted. You there?
Yes, I'm here.
So do you want to add anything? Yeah, I can hear you. You want to add anything as a MFM fellow?
Nope.
I'm not an MFM fellow. I've never pretended to be one.
Nope.
I mean, because when I was a resident, we used to do anything less than 32 weeks. And then I read that in Up to Date, and I'm like, well, okay, I guess things changed.
Yeah, maybe they have, I mean, I think that where I'm practicing fellowship, we're still doing 32 weeks also, and that's what we did in residency, but
But then when you look at the weight of 1500, when are you 1500
right around 28 weeks. So
exactly? So that's why I'm like, maybe they changed things.
yeah, that,
I
mean,
don't know. It's kind of hard because you have, some of these babies now that, they're super preemies, 23
Mhm.
weeks, and the patient ends up with a classical because they're breech.
right.
In the old days, we delivered those vaginally, and now we're supposed to section them, and it's like the patient, a lot of times the baby doesn't make it, and she's going to end
Right.
up
Then
with
you
a
have to do
C-section for the
surgery.
rest of her life. I don't know what the right answer is. You
Absolutely.
can ask some of your attendings, and you can write it in the box for future. I mean, I don't know what the right answer is. I'm just telling you this is what up to date says.
Yes, no, I'll definitely ask and see if they've read or know anything different.
Cool, awesome, because it'd be just good to know.
Absolutely.
All right, are you looking for anything in specifics? Anything else? So then you said the pearls of excellence said 32 weeks, and then the NIPS, but then Jay said, I guess the
Yeah,
Natera
so then maybe
is
there's different
allowing it.
specific labs that might do it differently. I know the one that we use
Yeah.
doesn't, but I think that there's probably lots of variation in that.
And I remember when they first came out, you couldn't do it on twins. Look,
Right.
that changed.
Yes.
That was several years ago. So what you looking for? GYN, I'm assuming? I already hit you hard with that anterior repair, right? Now pressure,
Yeah.
pressure.
But
Pressure. That I remember.
another GYN case would actually be great though, I think.
Do you have
The
one that's
pressure is big to
concerning you?
learn. There is this one actually. Let me see if I can
Okay.
find it. It is also another vaginal hysterectomy.
Okay.
Where is it? It's not the anterior repair. I'm sorry, I'm just looking for it. There were two that I had. Either case, actually, any of the GYN cases would be fine. They're all troublesome to me.
You sure?
Yes.
Okay. Hold on a second. I already found one. Case 12.
Case 12. Oh, okay.
Why did this patient have a fallopian tubal?
So my GYN cases, at the time that I was doing all of these, I was a resident. So unfortunately, I was not part of the decision-making process for the mode of sterilization. However, if that was something that I were to do now, I would definitely have an extensive talk with my patient to talk to them about the benefits of doing a bilateral salpingectomy versus other modes of sterilization, such as like a fallope ring or even like partial excision.
So why is it beneficial to do the salpingectomy?
And so the salpingectomy, a bilateral salpingectomy has been shown to decrease the rate of ovarian cancer by 30 to 60%.
Now, if you had a tubal, is that beneficial?
No,
in some way?
the Pomeroy or the Parkland like tubal ligation process is like are you referring to like a partial excisional procedure?
Like a fallope ring?
Oh, okay. No,
Hershey clip?
those would not decrease your risk of ovarian cancer because it's believed that the origin of the ovarian cancer is in the fimbriae of the tube.
So of all the different ways of doing a tubal ligation, why was the fallope ring chosen in this case?
I think that this is just what that provider specifically did for all of his sterilizations, and I honestly could not speak to the discussion that was had with the patient about it.
So can you discuss for me the 10-year failure rate of the CREST study regarding the different modes of sterilization?
That is something I would have to look into to go into all of the different modes, but I do know that the failure rates for the fallope ring at, I believe, the 5-year and the 10-year mark are, 10% and 20% failure. For a salpingectomy, we don't have outcomes looking at 5 and 10 years currently, as this recommendation was made only a couple of years ago. And I could not tell you about the excisional procedures off the top of my head.
So you're saying the fallope ring may not have been the best choice?
Yes, I definitely am saying that. I think that there are better options for sterilization, such as the excisional parchment.
So what other options are there that are occlusive? Not necessarily like a Pomeroy, the occlusive like a ring. What else is available?
There are also the fishy clips that you can do, and there's also just cautery, which I have never used either of those methods.
So with the cautery, does it matter what type of cautery you use?
I don't understand the question. Just in terms of like which form you use the cautery in?
Yeah, let me ask you this. What different types of cautery can you use?
I suppose you could do like an end seal to cut part of the tube off, but I feel like that would still kind of be more of an excisional procedure versus just simply using cautery that would just burn parts of the tube, which once again, I'm not sure. I've never used the cautery for sterilization procedure.
So what would be more beneficial, bipolar or monopolar?
I would say bipolar, because you would be able to have an instrument on either side of the tube, making sure that you're getting the full thickness of the tube if those were my only two options.
So let's say between a Hoka clip, a fallope ring, or a Filshie clip, which one would be the best of those three methods for tubal ligation?
You said a Hoka clip, fallope ring. I would think the fishy clips, but once again, that is a complete guess. I need to review the CREST study.
So why Filshie clips? Why did you just guess Filshie clips?
Because from what I recall, the clips go all the way around, whereas the fallope ring, really, you have the segment of the tube that's pulled up and then goes just on top of that, which seems that it would pop. It has like the potential to not have, how do I explain this? Not have like the tube fully occluded, if that makes sense. So I believe it would increase your risk of failure and increase the risk of ectopics.
What about a Hoka clip?
I couldn't tell you.
What if I told you when the CREST study was performed, the Filshie clips were not part of the study?
Oh, then I would say that I definitely need to review the study.
I'm going to be honest with you, because you have this in your case, you got to review the CREST study. Not that I'm very good at it,
Okay.
because this sticks out like a sore thumb, especially when everybody does salpingectomies.
Right. Okay.
Yeah, I don't know if I would have put this case on my list.
Okay.
But I'm sure they're going to ask you about CREST, so you better review that. So there you are. Maybe it is a good thing to put in.
Do you think it's reasonable to say, of course, knowing the facts of the CREST study and all the different types of sterilization, but to just say simply that I was not part of the discussion and I was a resident at the time and this is not what I would do?
But unfortunately, the cases that are on your list, you have to treat them as your own.
Okay.
Unfortunately. So I don't have an answer for you there. You have to.
Okay.
I mean, I've done things in the past with candidates where they have patients that do not want a salpingectomy. There might be the Medicaid in their state only pays for tubals and not for salpingectomies. Or I know a lot of Native American patients do not like parts of their bodies removed.
Okay.
So they prefer the clips. And I mean, the Filshie clip, you're correct, would have been better than a fallope ring. So I guess you could say that's all they had at my facility.
Okay.
I don't know what to tell you. And I'm not saying to lie, but there's always ways of fudging things and stuff like that. But still, they can still ask you about the CREST study. They may accept your explanation, well, she's a Native American patient, Okay, yeah, but tell me about the CREST study, because that sticks out like a sore thumb. You know what I'm saying?
Absolutely. Okay.
So Filshie clips were not used in America during the time of the study. Failure rate of the titanium clip, which is the fill sheet clip, is suspected or thought to be 0.4% based on studies within a 6 to 15 year follow-up, comparable, if not slightly better than the methods from the CREST study. Okay, the worst of all of them is actually the Hoka clip. That's a 36.5 out of 1,000 failure rate.
Oh, wow.
Monopolar is 7.5 out of 1,000, and bipolar is 3.2 to 6.3 out of 1,000. The fallope ring is 17.7 out of 1,000. Postpartum tubal was 7.5 out of 1,000, and the Hoka, like I said, is the worst at 36.5 out of 1,000.
Okay.
And that's something that I looked up. I know there's different interpretations of the CREST study, to be honest with you, but that's
Okay.
just in a nutshell. So the worst one is actually the Hoka clip. The field sheet clip, by extrapolation, appears to have been the best, even though it was not studied. So
Okay.
I guess you could say you're better than the Hoka clip, but not as good as the field sheet clip being a fallope ring.
Right.
I mean, even with the stats there, you were better cauterizing.
Yeah, absolutely. So you said the float was
So
17.5, right? And then,
Yep.
okay.
Yep. Again, there's different interpretations of the CREST study, but you have this in your list. I would know it cold because I could see somebody just rimming you on this.
Okay. Thank you.
Okay. Yeah. I mean, again, I know you were a resident. You could say that, but I think they could always backtrack and say, yeah, this is on your list. You got to own it.
Absolutely.
You know, in the end, you have to own everything that's on your list. But it's a thing that would bring attention for sure.
Right.
So it
Hopefully we
could
can talk about the
possibly
CREST
be a
study
CREST
for a while.
study. Yeah, exactly. Okay.
Okay.
All righty. Awesome. Good job. Let's put in, I mean, we're 6 minutes past, but I have no problem getting one more person in. I'm coming to Ruby here. You there, Ruby? Ooh, says yourself muted. Are you there, Ruby?
I'm here. Can you hear me?
Oh, yeah. Finally, it worked. How you doing, my friend?
I'm good, thank you.
You good? Are you a generalist, subspecialist?
Generalist.
Generalist. Are you looking for anything specific? This will be a short one, but at least we get somebody else in the hot seat, so that's a good thing.
Yeah, we can do something in office or anything,
Okay.
whatever.
All right. Go see what we got.
My list is under September. If you're
Ah,
looking, yeah.
I'm looking. I'm like, I don't see it. I don't see it. Hold on a second. Have you told Beth to move that forward?
No.
Just
Okay, I
shoot
guess
her,
I can.
shoot her an email.
Okay.
Because if you didn't say that, I wouldn't have known. Okay, I'm just looking through it. Okay.
Okay.
So case number 32. Can you go into the detail of the discussion you undertook with the patient in regards to her treatment options in regards to her fibroid uterus?
Okay. So this is the patient that just came in for a routine visit, and she's had this known fibroid. And just wanted to assess, like, to see where the status was, and had no plans yet for fertility and had no plans for surgical management. I did advise her, I mean, given her age, she's 34, she's G0. The fibroid is likely to continue growing. But the only symptoms, so to speak, that she had is just the fact that it was protruding, but it wasn't causing any heavy bleeding. It wasn't causing heavier or, I mean, more significant pain during her menses, and it wasn't um, affecting like urinary or GI tract.
So let's say she comes back a year later and now she's complaining of abnormal uterine bleeding. She has some bulk symptoms. How would you counsel her about all her options? I want all options so she can make an informed decision.
Okay, so we can, now that she's having abnormal uterine bleeding, now we depending on where she is in terms of surgical management, if she's saying that she still wants to do kind of medical management, we can try NSAIDs and oral contraception. And as for more medical management, we can also try, particularly if she's trying to move on to surgical, we can try a Lupron injection to try to shrink the fibroids prior to surgery.
Any other medical management?
We can also offer her uterine dislocation, a uterine artery embolization. However, I'm not sure. I wouldn't necessarily advise her towards this just because they tend to cause significant pain.
So what are contraindications to a UAE?
Contraindication is include if they still desire fertility. Let's see. I want to say if it's subserosal, I'm not sure if I would actually give that offer a UAE.
Why not?
Because if it becomes necrotic, there isn't anywhere for it to go other than inside the abdomen.
Any other contraindications to a UAE?
Nothing that I can think of right now.
How about more towards medical management?
Given that her fibroids are subserosal and intramural, we could also, if it's just management of the abnormal uterine bleeding, we can do IUD as well.
Anything else? I want all management options.
Okay, well then, so yeah, then we can do all the options. So pills, we can do NuvaRing, we can do Depo-Provera, and well, I wouldn't necessarily recommend Nexplanon for abnormal uterine bleeding.
Why not?
Because its most common side effect is irregular bleeding.
But if it's less than what she's experiencing, would that be better?
True.
Same thing with the IUD, right? Is any irregular bleeding a side effect of IUD? The Mirena, for lack of a better word?
Yes, but it works to reduce your bleeding.
But the Nexplanon doesn't reduce your bleeding?
I have found that most of my patients have had more bleeding. Some of them. Yeah.
So what if the patient says, you know, doc, I'm not too keen on hormonal treatment? What options are there?
I mean, for non-hormonal management, we can do, and still medical would be a Paragard IUD.
Why a Paragard?
It's non-hormonal.
Yeah, but that's going to help somebody who has fibroids?
No, it is not. No.
You're thinking too much into it.
Okay. Non-hormonal medical management. Oh, I said NSAIDs.
In the same vein as NSAIDs, what else?
I can't think of it.
About Lisetta?
Oh, yes, yes. Lisetta, tranexamic acid.
Okay, so what's the dosing there?
Mm. I want to say it was 600 milligrams.
I'm gonna tell you, it's 1,300 milligrams TID for 5 days
Okay,
while you have your period. Okay.
thank you.
Anything else? They got some newer medicines. They have commercials. Isn't there a new thing called Mefimbre? Am I saying it right?
Okay.
Heard of that one? It's a mix of medications like Orlissa and some other stuff.
But aren't those more for endometriosis?
This one's for fibroids,
Okay.
if I'm not mistaken. If you want to look that up. So what
Okay.
about surgically? What are you offering the patient?
Surgically, I would offer her an open abdominal myomectomy with it's a 17 centimeter uterus. So depending on the location of the mass on her abdomen, it would determine whether I do a fan and still versus a midline vertical incision.
Would you offer her an ablation?
Endometrial ablation? No.
Yes. Why not?
No. Because she is 34 years old, and depending on her future fertility status, I would not recommend.
But do you think a 17 centimeter uterus would benefit from an endometrial ablation?
Correct. It would not either.
You could do a Novasure on that. You think the little fan will get that far?
No, not at all.
All right, we'll stop there. So when they say I want everything discussed, you got to go to all your basics,
Okay.
right?
Yes.
Okay. So tranexamic acid, like I said, 1,300 milligrams TID for 5 days during her period. Contraindications to uterine artery embolization, future fertility, postmenopausal, contraindication to contrast agents. You're thinking of pedunculated fibroid that has a narrow stalk. The stalk is less than 50% in diameter to the fibroid. The fibroid could detach and lead to sterile peritonitis. This is directly from the up-to-date article, but then the next line it says, but this has never happened in practice. I would have to look up what the Mefimbre has in it. I mean, I don't think it's that great of a commercial. I wouldn't use the product looking, but she's with her family, so that was very nice. They always do all those like family things, and you're thinking about your IUD because those are like good commercials. She's not a candidate for an ablation because it's too big of a uterus. The thought process of giving depo before a myomectomy, it makes it harder to differentiate the planes sometimes. So some people are not proponents of giving it. Some people do give it. So I don't know what to tell you question-wise in regards to that. I've never heard the Nexplanon not being an option because it does inhibit ovulation. It also decreases that or thins out that lining of the uterus. So you should have some irregular lighter bleeding, but I never heard that it caused heavier bleeding. Any of my patients anyway. So I have no answer to tell you on that one.
Not necessarily heavier, but like more like persistent bleeding. So, which in essence is not ideal.
But the IUD could do that too, no? I don't have a good answer for you on that one. You got me on that one. Any other questions? Because I have a bunch of questions I have to go through.
No, ma'am. Thank you.
All right, good job.
Thank you.
All righty, very good. So I here have some questions. So timing for PMS versus PMDD regarding to the menstrual cycle. So usually it's going to be the week before the cycle, usually the symptomatology, to my understanding. Okay, so Hopefully that answers your question. Can you repeat the question that was asked regarding 32 weeks? It was a question of when you should deliver, when you should not deliver a twin B as if it's a breech vaginally. I have read an up-to-date 28 weeks. When I was a resident, it was 32 weeks. Priyanka, she's an MFM. At her institution, they're doing 32 weeks. She's going to kind of ask some of her MFM attendings, see what they say. So up to date, I know it says 28 weeks, but Priyanka says the excellence of Pearls of Excellence says 32 weeks, and that's what she's used to doing in her practice, and that's what I used to do when I was a resident. So I have Shilpi saying maximum amount of vasopressin should be 4 to 6 units, so diluting 100 cc's into 20 units means that you use 20 cc's to 30 cc's of this solution. You can dilute however you like, but you shouldn't go over 4 to 6 units in total. This is from up to date. Well, there you have it. I stand corrected because I don't use the vasopressin. I use something else. The fill sheet failure rate, this is according to the extrapolation, is 0.4%. So they want, Emilia wants to go over the failure rate of each. So this is from an interpretation of the CREST study that I read. Monopolar is 7.5 out of 1,000 procedures. Bipolar is 3.2 to 6.3 out of 1,000 procedures. Postpartum tubal is 7.5 out of 1,000. The Hulka clip or the spring clip is 36.5 out of 1,000. The fallope ring is 17.7 out of 1,000. Fill sheet clip is 0.4 being extrapolated. Okay. So Vanessa is saying Mefimbre is for endometriosis. I think you might be thinking Orihan, which is heavy menstrual bleeding due to fibroids. Maybe I am. Could have sworn I saw the commercial Mefimbre saying it was for uterine fibroids. I would have to double check that. That's like newer stuff. I'd have to look it up. I have not looked that up myself. Okay. So hopefully we've answered everybody's. Okay, so Emilia is saying Mefimbre was for fibroids, but has just been approved also for endo. So this is, Ruby looked this up for us. She's saying Mefimbre is indicated in premenopausal women for the management of heavy menstrual bleeding associated with uterine fibroids, moderate to severe pain associated with endometriosis. All righty. Hopefully we answered everybody's questions. Anybody else have anything else that is still outstanding that has not been answered? I'm just looking here. I think we got everybody's questions answered. I appreciate it. Thanks, Elizabeth. You know, I'm just a generalist. I try my best. I'm not saying I know everything. I guess if I knew everything, I'd be working at Harvard, which I don't. That's a joke. I'd be in the Ivy Leagues. Any other questions before we let you guys go? I think we had a good session. I think we had some good topics. Any other questions before I let everybody go? I'm going to stay on for a couple of minutes. If anybody has any suggestions or recommendations on how to improve the webinars, I'll stay on and you can type those in. This will be private. Nobody will be seeing them. So we're always here trying to improve on Exam Pro. So at this point, if nobody has any other questions, I'm going to let everybody off the call. I hope everybody has a good week, a good rest of the Sunday, and a good week coming up. And I wish everybody a good night. And I'll stay on to see if anybody has any recommendations or suggestions on to improve these webinars. So I appreciate it, guys. Thanks for sticking it out. And I appreciate everybody that participated. Everybody did a great job. Thank you so much. And continued good luck with your studies. Have a good night.